Okay, we'll get started. So, we finished with blood. Now we're moving on to the cardiovascular system. This is when things are start being put together a little bit. Pull things in from chapter 1, general phys, a little bit of neuro, all gets involved here with the heart. And this is when systems start getting put together. Our objectives for the lectures. Overview of the cardiovascular system. It's the heart, blood vessels, and the blood. The blood is involved. The blood is a major factor that influences how the cardiovascular system works. The cardiovascular system is just a pump. That's all it does. If you have a pool at home, if you ever had to fool around with it, the pump that's on all day is like your heart. You're pulling in blood or water into the pump. You're pushing it back out. So it's kind of like a heart. What the heart does, it pressurizes the blood. Blood is a liquid. It's not air. Air you can compress. Blood you can't. As you start to squeeze blood, it pressurizes and the pressure goes up, generating pressure to allow blood to move. And it provides that driving force. The pressure that the heart generates provides it's like if you go on a roller coaster, you have to get to the very, very top, and then after that, you just go. Well, your heart is pressurizing while the track is going all the way to the top. And once your heart squeezes, then you have the rest of the energy that allows you to go the rest of the ride. Substances are transported throughout the system, either materials that are enter the body from the external environment, oxygen, pathogens that can get in there, materials moving between cells and the body, your waste products, CO2, oxygen going from the blood to the tissues, and waste products. So urea, lactic acid, these are waste products. They have to go back into the blood where they then can be either washed out, brought to different tissues and organs to be taken care of. All the exchange between the blood and the interstitial fluid only occurs at the capillary level. There is no exchange of anything in arteries or veins. It happens in the capillaries. And we'll talk more about why later on when we get to that area. We talk about the cardiovascular system, we may say right side circulation. The right side circulation is the pulmonary system. Right ventricle pushes the blood to the lungs, which then returns back into left atrium. But so the right side of the heart is the pulmonary system. The left side is your systemic, or the body. Leaving the left ventricle, pumps to the whole body, and then eventually comes back through the right atrium. So left side is the body, right side is the pulmonary system. Okay, this is very important later on when we get to like heart failures. If you have left-sided heart failure, you can't pump blood to the body. If you have right-sided heart failure, you can't pump blood to the lungs. So like I said with the light switch, the first day class, knowing the pathways, we're going to learn the pathways so you'll see where all these symptoms come into play. The pulmonary and systemic circulation are in series with each other. Those of you who hated physics, we're bringing it all back right now. Okay? The whole cardiovascular system is all physics-based. You don't need a calculator, but you'll see where they come in. So, in series, okay, we have the pulmonary circulation, we have the systemic or the body circulation, I'll put systemic. And then it goes again to the pulmonary and the systemic. It's in series. They go one after the other after the other. The blood has to go through the entire pulmonary system, then it goes through the whole systemic system, then it goes back to the pulmonary, they go back and forth. This is in series, okay? The pulmonary system has low pressures, and that allows the driving force from a high pressure in the aorta all the way down to the right atrium. That difference allows your blood to go from the aorta to the arteries, capillaries, veins, and back up. Systemic circulation by itself is in parallel with higher pressures. So what does that mean? Do I have a picture of it? Yes. So here's what this means. All of these are in parallel with each other. So the pressures are evenly distributed amongst the systems. So if you add up all of these, you get your systolic blood pressure, and you can break it out to the pressures to different areas. Don't worry about this right now, just know that it's in parallel with our systematic circulation. When it comes to pulmonary and systemic, they're in series with each other. So let's talk about hemodynamics. Pressure. We measure pressure in the system by millimeters of mercury, and you guys do your blood pressure readings. That reading that you check for blood pressure clues us in to what's going on with your heart and how much force it has to generate. Flow, we talk about flow of the blood, occurs in differences between pressure between 2 points. So the higher that number of flow, the better that blood's going to move through that area. The circulatory system is closed. Okay? There's no way to get more blood in unless you put an IV. There's no way to lose blood unless you, again, cut your vessels to lose blood. But whatever leaves the heart should come back to the heart. Make sense? If you're pumping out 5 liters of blood every minute, you should be receiving 5 liters of blood back into the heart. It's a closed system. Blood can't compress, so when the ventricles start to squeeze, the blood gets pressurized, creating the potential for blood flow. We need to generate the pressure, bring you up to the very, very tippy top of that roller coaster so that when the blood leaves the heart, just natural flow allows it to move through the whole system. The amount of flow between 2 points is also dependent on resistance. What is resisting the flow of blood through your vessels? Okay, Ohm's law, right? I told you physics. Okay, Ohm's law, we're relating it to fluids now. Ohm's law states that flow, which we call Q, because we're dealing with the cardiovascular system, Q is also cardiac output. So whenever you see the word or letter Q from now on, associate Q with cardiac output. What's the rate of flow leaving the heart? Liters per minute. It's a flow rate. Okay? Is proportional to the difference in pressures from one point to the other divided by the resistance. So, if I increase the resistance to blood flow, what happens to my flow? Decreases the flow. I'm increasing the resistance between you and this other point. Can you get there fast? No, I'm in the way. I'm providing resistance to you moving, so the flow has to go down. Likewise, the bigger the change between one point and the other point, the wider that difference is, the more easier flow is as well. Okay? So let's talk about resistance now. What determines our resistance to flow? And this is Poiseuille's law. Okay? I wasn't joking about the physics. It's going to come right back in pulmonary too. So it'll come right back there. You don't need to memorize the laws though. Okay? I don't care what Ohm's law is. I know you need to know what it means. Why does it matter for cardiovascular? Why do Poiseuille's law, we're talking about it right now, why is this important? I don't care what you know what Poiseuille's is, but do you understand why it's important? So the tube, which is our vessel, right, the arteries or the veins, will offer greater resistance to fluid flow if the length increases. So the longer the tube, the greater the resistance to flow. Do you ever try drinking a straw and you put a bunch of straws together and then you try and suck the fluid out? You can't do it because why? You have to generate much more pressure in your mouth to get across that long distance. The resistance went up. So that's the length of the tube. Or if the radius decreases, the radius of the vessel, if that vessel gets smaller, and what do we call that when a vessel gets smaller? Vasoconstriction. We're talking about a vessel now. So vaso just means vessel, constriction. In this section, you really got to pay attention to the words. We're going to talk about arterial constriction. That's just constriction of the arteries and the arterioles. We may talk about venoconstriction. That's just with the veins. When we talk about vasoconstriction, it's just vessels in general. Okay? So if you vasoconstrict the vessel, the radius gets smaller, the resistance through that tube goes up. And it's a factor of 4. It's the 8ln, we'll go over those in a second, over pi radius 4 cubed. So when you change vessel radius a little bit, it produces a big change in the resistance. Likewise, if I give you a drug that's going to cause vasodilation, now the vessel gets bigger. What's going to happen to the resistance to flow through those vessels? Decreases. I've increased the vessel size. Start thinking about resistance as the blood pressure. If I increase the radius of the vessel, the blood pressure is going to drop. That's what a lot of target of the medicines that you give are targeting these smooth muscles of the arterioles to cause vasoconstriction to raise your pressure or cause vasodilation to drop your pressure just by altering the radius. So resistances are, the L is the length of the tube. That little n is the viscosity of the fluid. We don't really mention this very, very much because for the most part, our blood is pretty consistently viscous at a normal, whatever you want to call it. I don't know what you call it. We mentioned before polycythemia. What's that? Increased cells. Okay, when you have a whole lot of viscosity, the blood gets a little bit thicker and it's harder to move through the body. Okay, that's what that's talking about. But we don't really mention it that much unless you're in an environment where the patient is severely dehydrated, whatever. There'll be a certain condition where you'll worry about the viscosity. 98% of the time, you don't care about it. So we're not going to worry about it unless I tell you. But for all we need to worry about in this class is the length of the tube and the radius. Resistance, okay, radius is the dominant variable to the 4th power. If you double the vessel radius, you increase flow 16-fold. So big, big changes in flow. And we control this through vasoconstriction and vasodilation to alter your flow through the system and change your pressures. So, those of you who've given IVs before, okay, the reason you give boluses of fluids through a AC is because large bore peripheral IV Large bore means the radius is big, right? And the length of an IV is really like that long, really. So we have a short length, large bore. Flow can go very, very, very easily through this. So if you want to replace fluids with someone, use a peripheral line. It'll flow faster. Short length of the IV, large bore for the radius. Both of those things promote flow and decrease resistance. A central line will also have a large radius, but a central line is very long. It goes in your neck and it can go, inches. The length of a central line decreases the flow. So it's very good for like medications, but don't put fluids through there. It's not going to be fast enough because the resistance to flow is too long with the length of that central line. And that's where that correlation comes in and why you pick certain IV sites. Now, this one, star, whatever you want to do, this is one of those definition words you got to know. Compliance. How compliant is the structure? How compliant is your left ventricle? Compliance discusses the distensibility of a structure. How relaxed can it get? Can it accommodate a certain amount of volume of blood? And it does that with compliance. If you have, so it's the ability of the heart to hold a volume of blood with low pressure buildup. We can hold on to the blood, but still have a low pressure. Why? Because the heart is compliant. It can accept and get bigger when a bigger amount of blood comes into it. That's the compliance. If the heart wasn't compliant, it would be very stiff, rigid. It won't expand very well. And you're going to get changes in pressures when your heart loses compliance. Think about a garden hose. A brand new garden hose is very pliable. You can bend it and do all you want to it. If you leave that garden hose out in the sun forever, you go to it again, it got harder. If you try to bend it, it's going to crack. It lost its compliance. Okay, so that's what compliance is. As the heart weakens, it gets stiff. Changes in blood volume produce large changes in pressures, and the compliance goes down. So let's draw out, this graph is going to be all the stuff we do through this entire section in cardiovascular is going to be talking about this one graph that we're going to start to build together. So when we build up this graph, on the x-axis is volume. And because we're dealing with the cardiovascular system, it's going to be in milliliters. The y-axis is going to be pressure. Okay, in millimeters of mercury. So we're establishing a pressure volume loop that we're going to start here. But for now, we are talking about compliance. And compliance, we're going to do this right here. Changes in volume over changes in pressure. And that's what we're going to do graphically right now. So here's our pressure points. 100, 80. And here's our volumes. Doesn't matter what it is. Okay. We're going to draw out just the compliance line right now, and it's going to show you what compliance means. So what is compliance? The change in volume, right? So let's draw our volume. We're going to draw one line. That's it. This one line is our compliance line. So now let's look at this. We have that is the volume change. Volume is going up, right? As we go from left to right. The volume is increasing, right? So we're moving all that line goes all the way across. Now, let's look at the y-axis. This big addition of volume of blood only produced a 10 millimeter mercury of change difference. So we're able to hold on to like 70 mLs of blood in the heart with very, very little change in pressure. That is the compliance line. If I say your compliance got worse, which way would this line have to go? To the left and up or the right and down? If compliance gets worse, why would it go left and right, left and up?
Because the pressure is going to increase.
Pressure is going up. So let's change the color now. So if we were going to make compliance worse, this line shifts up here. Now look at our starting pressure. 10 to 20, we were at 0 to 10. Pressure has gone up for the same amount of volume. So in this case, compliance decreases. And let's do one in green. So if I say compliance increases, so the green, compliance increases. The line is lower. We're on a lower pressure line. Yes?
Isn't it supposed to be change of pressure? So if it's 0 to 10 and 10 to 20?
Well, we're starting at a higher pressure, though. So you were at 10, but now we're starting at 20, going from 20 to 30. We're increasing the pressure line where we are at the pressure.
Right, but the difference.
The difference doesn't matter. It's where you start. We're higher on the pressure gradient line where we start. So if you decrease compliance, now we start at whatever number this is. I'm just hypothetical numbers here. These are not real. We'll fill them in later. We're higher on that line versus the red, which is the normal. We're lower on that line. Don't put where the numbers. That could probably confuse you more. As compliance decreases for the same amount of volume, you're at a higher pressure. As compliance improves, same amount of volume of blood, but the pressures are lower. So if I say your compliance improves, you're able to hold the same amount of blood at a lower pressure on the heart. Okay, so that's compliance. Okay, you'll see why I drew it this way. It's going to make sense in a little bit. Okay, if you guys watch Karate Kid, okay, you guys are all going to get Miyagi later on throughout PA school and AA school. You don't know what you're doing, all of a sudden that all comes together like, oh, now I know why we're doing it this way. The same way that I teach. We put pieces together and then we'll put them all together. This is one part of the cardiac cycle. We're going to add more lines to this. But this bottom line, associate, that is your compliance curve. Okay, it's always going to be there. We're going to alter it depending on what happens to the patient. Okay, so those are the hemodynamics. Now let's talk about structure and function of our cardiac muscle. So this is the anatomy of the heart. The blue lines say the direction of the flow. Diastole, the heart is bigger because it's filling with blood. Diastole, associate with filling, rest, relaxation. Those are all words associated with diastole or diastolic function. It's the resting of the heart, the filling of the heart, the relaxation of the heart, because the heart has to relax to accommodate all the blood that's going to come into it. Systole, heart gets smaller because the heart is now squeezing to get all that blood out. It squeezes because it's got to compressorize or pressurize that blood so it can get squirted and goes out. Okay? So systole is squeezing, it is ejection. Those are the words for systole. So cardiac muscle is striated just like our skeletal muscle is. It's aligned in sarcomeres. It's got those cross-bridge cycling going on. Troponin C, T, and I are here, all on the tropomyosin. So all that stuff is going to be there. We have to add a different wrinkle to it here. In cardiac muscle, the myocytes are surrounded by a sarcolemma, but they also have this function called a transverse tubule or a T-tubule. And what T-tubule does is it extends a little bit inside the cell. Main job of all this is for calcium. Every sarcoplasmic reticulum is with every T-tubule. What does a sarcoplasmic reticulum store? Calcium. So every T-tubule is going to have an SR right next to it. This will come into play in a second when we get there. Myocyte connections occur at these intercalated discs, which have the gap junctions. Gap junctions, electrical conductivity, so connection between the heart, all going to be electrical. And one single action potential in any one cell of the heart can cause the entire heart to beat. Just one cell. Because of all these gap junctions, the electrical impulse spreads fast. All it takes is one. That's why if you've ever had a premature beat, you feel an extra heartbeat in there, that's because one cell in your heart got irritated, sent a signal to depolarize, and then the whole heart depolarizes, and you have a heartbeat. And it doesn't happen when it normally does, so you feel an extra beat in there. Okay? Excitation, contraction, coupling. Same thing we talked about with skeletal muscle, it's here as well. You have to excite the tissue first, cause depolarization, then you can have the contraction occurring later. Cardiac muscle can contract without nervous stimulation. So if you cut the heart out, you let it on a table, it will beat by itself for a little bit, and then obviously the energy stores are depleted, they go away. But if you can keep, perfusing your heart with blood, it'll keep beating on its own. It'll do its own thing. Normal heart rate, if you let the heart do whatever it wanted without any nervous input, the heart rate will be around 100 beats per minute. It gets lower because of what autonomic nervous system is in control most of the time. The parasympathetic is in control most of the time, so your heart rate comes down to like 70 or 80 because your parasympathetic system is in control right now. So the pacemaker cells generate the action potential. This action potential is conducted along those T-tubules, and that is where our first calcium channels are located, inside these T-tubules, and they dump calcium into the cell. Everyone's good here? This is kind of like where we were with our nerve cells. At this point, we would talk about exocytosis with neurotransmitter release. But now we're talking about cardiac cells. So when this calcium gets dumped into the cell, it causes a spark. And this spark is called calcium-induced calcium release. When the calcium comes into the cell through the T-tubules, it causes the SR to dump its contents of calcium into the cell as well. So the calcium induced from the T-tubules into the cell, calcium release, it causes this SR to dump its contents of calcium into the cell. Calcium-induced calcium release. It's a double dose of calcium, essentially. Okay, and all these calciums, they're going to do the same thing we just learned last unit. They're going to bind to the troponin C, cause it to get out of the way, cause cross-bridge cycling to happen. Same exact thing with skeletal muscle as far as what calcium is going to do. Okay? But then we have to get rid of that calcium. We can't let it stay there. We have to have their muscle relax too, so we have to get rid of it. So we have two ways of doing it. We have a calcium-sodium exchanger that's going to dump the calcium back outside the cell. And we have this calcium ATPase pump. It's going to pump the calcium back into the SR. So those are the ways we can get rid of calcium. Because the heart has to relax. So we have to get rid of the calcium. So with cardiac muscle, when this calcium comes in through the T-tubules, from the active potential that's making its way all the way down, these voltage-gated channels in the T-tubules allow calcium to come in. The calcium that comes in triggers the SR to dump even more calcium inside the cell, which then is going to bind to all the troponins, causing cross-bridge cycling, so you have a contraction. We get rid of calcium, sodium-calcium exchanger to get it outside the cell, and that calcium ATPase pump to get it back into the SR. Everyone good? That's the special part for calcium. That's the most important part for calcium. That's all you gotta know. Okay, everything else is gonna be built off of this. So, here are these T-tubules, and they come down. Okay, this is where the calcium channels are. Calcium comes in. Here's your SR. Tells the SR, hey, dump even more calcium. And there's that calcium-induced calcium release, or that's calcium spark. And all these calciums then going to bind to the troponin C, and they cause all that stuff to happen from there. And then ATPase pump, sodium calcium exchanger, puts the calciums back to where that needs to be. And here's another way of looking at it as well. Okay, excitation or depolarization occurs. Voltage-sensitive plasma channels for calcium are there. They open up. Calcium comes in. Stimulates SR to dump even more calcium out. And all this extra calcium provides the contraction and the squeeze. Everyone good? Okay. So, a drug that increases, this is a clinical correlation, but this, if you can understand, walk yourself through this one, this is like a really good one as far as explaining why things happen the way they do with these concentrations. And this explains why that sodium-potassium ATPase pump is so important to maintain those membrane potentials. So any drug that's going to increase intracellular calcium is going to increase myocardial contractility. The heart is going to squeeze harder the more calcium that you have in the area. Okay? Digitalis or digoxin is a drug that we give, and it increases myocardial contraction. That's one of the roles of digoxin. And what it does is it increases the intracellular calcium. How does this drug cause calcium levels to go up? What digoxin does is it blocks the sodium-potassium ATPase pump. If I block that pump, sodium is going to increase inside. Isn't the job of the sodium-potassium ATPase pump sodium back out? Well, I cut that channel off. That whole pump is gone now. So sodium is going to start building up inside the cell now. Because I blocked the pump, that's going to get rid of it. This increased intracellular sodium alters the electrical chemical driving force for that sodium-calcium exchanger. There's going to be more sodium inside the cell now, and that extra sodium is going to feed that sodium-calcium exchanger. So it's going to pump sodium out, and what's it going to bring in? Calcium. So we shifted that transporter. So now we're bringing extra calcium into the cell. More calcium in the cell, greater the contraction. Okay, so more intracellular calcium, more calcium in the SR, and every time you have another calcium-induced calcium release, more calcium gets dumped out because you're storing more of it in the SR due to blocking that sodium-potassium pump. Now, this is pretty advanced. Don't worry about this right now. But again, if you can work your way through it, you understand how these pumps work, maintaining the gradients. And when you don't maintain the gradients, this sodium-calcium exchange doesn't go in the right direction. We start bringing in a lot of calcium, which is going to make your blood pressure go up. Squeeze the heart better. Okay, take a break and come back at 2:40, and we'll start electrophysiology. Okay, we'll get started. So the next section that we're going into is the electrophysiology part. How does our heart generate a beat? Remember, we have to have the excitation-contraction coupling. So we have to excite the cells first before they can contract. When you're studying this electrophysiology, the cardiac cycle, everything that we go through just constantly repeats itself over and over and over again. So when you measure a heart rate, what do you measure? What's the units? Beats per minute. So let's say it's 60 to make it easy. 60 beats per minute. Well, how many beats happen in a second? One. So when we go through the cardiac cycles, just keep in your mind, this whole thing has to happen within 1 second. And if your heart rate goes faster, up to 100 beats per minute, then you have even less time to get everything done within that cardiac cycle. So we're going to break out the cardiac cycle into pieces. The electrophysiology, how do you get an EKG? We're going to go through that right now. And we'll go through the cardiac cycle, and then we'll be done for the day. So you say, yeah, but it's a lot of information. So it's a lot. So first thing, let's go over the conduction of the heart. The heart is mainly muscle. It has specialized cells, which are called autorhythmic cells or pacemaker cells, but these are the ones that actually will do the action potentials. All the rest of them are just myocytes, and they're going to behave in a different way because the myocyte is the muscle. Therefore, they're going to need a lot of calcium for contraction. The autorhythmic cells, the pacemaker cells, don't. They just need to fire. They just need to cause the depolarization to occur because remember, the heart, the entire heart, will depolarize if one cell depolarizes. In our hearts, that one cell area that constantly depolarizes all the time for us is located up here in the right atrium, and it's the sinoatrial node, or SA node. It's a collection of cells. They're autorhythmic. So when I said the heart will beat by itself without any nervous input, is because the SA node will continuously depolarize spontaneously. And it does it at a rate of 100 beats per minute, essentially. When the SA node depolarizes, it sends a wave of depolarization to the opposite side because the left atrium has to beat too. It also sends signals to another structure located right here, and this is called the AV node. Atrioventricular node. This is important because, I'm going to do it in black. This whole area between the atria and the ventricles, well, now it's all gone. That whole area is electrically inert. No electrical signal can get from the top of the heart to the bottom. It has to go through the AV node. And the AV node I just deleted. Right there. Okay. There's the AV node. This is the only place electrical activity can get from the top to the bottom. So if you ever heard of an AV block, it's happening here, preventing the signal getting from the top to the bottom. Top is the atria, the bottom is the ventricles. So the AV node is the only way to get from top to bottom. So the SA node fires, it depolarizes the atria, it gets to the AV node. The AV node is a capacitance node. It holds on to that charge for a split second. The AV node, waiting a little bit before it sends the signal down, allows one very, very important thing to happen to the ventricles. It allows the ventricles time to fill with blood. If the impulse went from the atria to the bottom instantaneously, the whole heart would squeeze at one time, you would have one heart sound, but no blood would go anywhere. So by waiting in that AV node for a little bit, allows the time for the ventricles to fill with blood before we send the signal to the ventricles, because once that signal hits the ventricles, they're going to squeeze whatever blood's in there. So at high heart rates, if you're running really hard and your heart rate's around 200, you have very little time to fill with blood. That's why at high heart rates you start getting winded and dizzy, because your heart just can't pump as much blood anymore. So that's the AV node. Once the AV node has held on to the charge, we get a little discharge through here, and it goes to what's called the bundle of His. Or His bundle. Just right at the top of the ventricles there. Now, once the impulse hits the bundle of His, we now have two branches that show up. And these are all nerves. It's all wires here, electrical impulses. So one, we have the left bundle that eventually comes up to make your Purkinje fibers. Purkinje fibers line the walls of the ventricle to allow the heart to squeeze appropriately. We also have a right bundle. And that right bundle, again, in the ventricular wall, and it works its way up. And it provides all these little nerves to, again, so the ventricles will squeeze together. When the heart squeezes, it uses the septum like a fulcrum. So the walls squeeze into the septum. It's like a tube of toothpaste between your hands. As long as both hands squeeze at the same time, toothpaste will squirt out. So when your heart squeezes, they come together. So SA node, AV node, bundle of His, Purkinje fibers. That's the order of these pacemaker cells. Any one of these things can take over your heart rate. If we knocked out, well, I'll tell you this. The SA node will fire around 100 beats per minute. The AV node will be 40 to 60. Purkinje fibers are 20 to 40. That means the SA node, if left alone, is going to fire every 100 beats, every 100 times a minute. Because the heart is a syncytium, the whole heart beats at once, whatever the fastest cell is, that's what everything's going to go against or go with. So normally your SA node is the fastest one, so the SA node controls your heart. If you had something happened and we knocked out your AV node, so there's no communication between the top of the heart and the bottom of the heart. So nothing is telling the ventricles what to do. The ventricles will go at their own rate. And what is the ventricle rate for the Purkinje fibers by itself? 20 to 40. So you see how some people come in with these complete heart blocks? Complete heart block means the top and the bottom don't communicate. Their heart rate is going to be like in the 30s and 40s because the Purkinje fibers are taking over to control the ventricular rate. So that's the conduction system. SA node to AV node. AV node hold on to the charge for a little bit, allows ventricles to fill with blood, then sends the signal to the ventricles, which are then going to squeeze, ejecting the blood to either the body or the pulmonary system. Everyone good as far as the different parts? These are the autorhythmic cells, the pacemaker cells. These are the ones that can control the depolarization of the heart. Okay? This bottom part, we're going to talk about more detail as we go. And we'll redraw it again. So, SA node action potential. Okay? These are pacemaker cells. The membrane depolarizes spontaneously during phase 4. So phase 4 right here happens spontaneously. And you can see how that line is creeping up towards threshold. Then, boom, we hit threshold and we go up. As we go from phase 0, sodium is still depolarizing the cell. But calcium is moving too, right? Don't we have calcium? And what's special about the calcium that comes into the cardiac cells? What does it cause? Calcium-induced calcium release. So you have a larger flux of calcium in these autorhythmic cells because now calcium is playing a role. Okay? Phase 0 in an SA node is slow, and the AP duration is shorter. Slow is talking about the slope. This is slower than that. Everyone understand that? If time is on the bottom, the blue is faster than the red line. Everyone get that? Because it's going to make a big difference when we get to the myocytes. Next slide. So this is just the SA node. This is all it does. Up and down, depolarizing, and that's all that it does. This is a ventricular muscle action potential. Okay, this is the actual muscle properties. They're going to need a lot of calcium. So phase 4 is our resting membrane potential, ground state, in between action potentials, nothing is going on. Phase 0, rapid upstroke, depolarization, right? There's your sodium. Rapid. That line is straight up and down. On the y-axis, or x-axis here, we have time. So go straight up and down so that action potential is very, very, very fast. Now, so we have our depolarization. In a normal nerve cell, at phase 1, what happens to our sodium channels at this point? They close due to what? The inactivation gate is there. The gate is still open, but the inactivation gate is there. So sodium now is done. No more sodium. It caused a depolarization. We're good. Now, phase 2 is called the plateau phase. At this phase, what channels, what voltage-gated channels are now open? Potassium. Potassium is wanting to go where? Out the cell or in the cell? Out. So potassium wants to go out. But we now have the calcium-induced calcium release. We had the depolarization occur. All the calcium channels opened up at phase 1. So now calcium has that spark. Where is the calcium going? Into the cell or out of the cell? In. Is going in. What is going to happen to the electrical activity if positives are leaving and positives are coming back in? Is there going to be any changes in electrical conduction? No. That's why you have that little plateau phase there. Because calcium is coming into the cell, potassium is leaving, positive is leaving, a positive is coming in. They cancel each other out. It's called this isoelectric point or plateau phase, whatever you want to call it, but it's due to the calcium-induced calcium release. This is why you have this extended phase there. You don't have it in the other cells. You don't have it in nerve cells because they don't have this calcium-induced calcium release. Now, calcium stops flowing, but potassium is still moving. So now calcium is stopped. Only potassium is moving. Which way is potassium going? Out. So the cell becomes more and more negative. And eventually the same thing happens now we did learn from before. We get all the way to the bottom. The voltage-gated potassium channels close. The sodium channels reset. And we're ready to start for the next beat. So every time this happens, there should be what happening right after this? When you see this on an EKG, what should you be able to feel immediately right after? A beat or pulse. Because that means the ventricles have squeezed now. Because they're going to contract. So you get a heartbeat. So, we have an EKG. We have a line. What's the first part of the heart to depolarize? The SA node. And where is the SA node located? In the right atrium, and it spreads to the left. So the first thing that happens, we get atrial depolarization, right? They're going to depolarize first, the atria. They're depolarizing. Sodium is moving, right? So what's going to happen to the resting membrane potential? Increase. So we get an increase right here. Then this little bubble comes back down. We get a little bump. This is due to SA node. This is called your P wave. And the P wave just means that the atria depolarized. It looks like this because this is what we are looking at. We are just looking at the SA node depolarization. That's it. And that gives us a P wave because the atria are depolarizing now. Now, after the SA node fires, what's the next electrical location that's going to be hit with this potential? The AV node. And what is the AV node going to do? Delay it. So the AV node holds on to the charge, and we get another flat line. There's no electrical activity happening because the AV node is holding on to that charge. So the AV node has held on to it long enough, and now the AV node is ready to fire it off down into the bundle of His and for the ventricular myocytes to contract. So here's our ventricular myocyte. Depolarization happens very, very, very fast, right? So we get a very fast line going up. Then we get that calcium-induced calcium release, the plateau phase. Is there any change in electrical when in that plateau phase? No electrical activity is happening, so this line comes back down, and we wait. So this is the plateau phase. This is all due to calcium. Then, what is the last thing that happens? What must the heart do after it depolarizes? It must repolarize, right? So, and we have repolarization. What ion is responsible for repolarization? Potassium. Only potassium is leaving. Cell gets a little bit positive, and then it comes back down. And we're done. That's an EKG beat, right? So AA, you guys did this already? Hopefully this makes more sense. So the P wave is atrial depolarization. Then we have a plateau phase. Oops. This whole area right here is called the QT interval. Well, not really all that, but don't put that. No. Anyway, calcium, potassium, sodium. Sodium is going to alter the SA node depolarization. Calcium is going to alter that plateau phase. Potassium is going to alter the repolarization. So this whole complex is called the QRS complex. This means ventricular depolarization. That is what's going on. The ventricles are depolarizing at that QRS complex. The last little bump is called the T wave, and that represents ventricular repolarization. And every beat, it just repeats itself. Okay, so P wave, it's atrial depolarization. When that happens, then the atrium are going to contract. Then the QRS complex is ventricular depolarization due to calcium, and then, or the full depolarization. Then the repolarization of the ventricles repolarization. Which one haven't we talked about repolarizing? Atria. Do they repolarize? Yes, they have to. Do we see it in EKG? No, because it kind of gets buried in the QRS. It's there. We don't look at it. We don't see it because the ventricles are a much bigger mass compared to the atria. So the ventricles will have a bigger amplitude than the P waves will. That's why this, talking about the atria, is very small compared to that amplitude of the ventricles is very tall. More muscle mass increases the amplitude. More voltages in that area, the higher that letter peak is. PAs, you will not be tested on EKG at all until the fall, but this kind of sets the stage as far as what EKG does. So clinical correlation, the antiarrhythmic drugs that you give for cardiology, they're going to act on certain parts of that complex. Class 1s are going to affect the sodium channels. Class 2 are beta blockers. Class 3, potassium channel blockers. So people have a problem with repolarization. You can give some potassium channel blockers. Class 4 are your calcium channel blockers. So if I talk about calcium channel blockers, what phase am I going to alter? The QRS, the plateau phase. That's where the calcium-induced calcium release comes into play. You don't need to know this for your exam. Again, just reinforcing stuff you learned about. You will get all this in Pharm in the fall with Dr. Wood. So, hierarchy of pacemakers. The SA node is the pacemaker of the heart because it has the most rapid depolarization for phase 4. So whoever depolarizes first controls the entire heart. SA node does it the fastest, so they control the heart. Normal sinus rhythm means, so if you say that someone has normal sinus rhythm, that means the electrical impulse started in the SA node, through the AV node, into the ventricles. That's what normal sinus rhythm means. Intrinsic SA node is about 100. Parasympathetic tone gets it to 70. If the SA node fails, the AV node will take over, secondary pacemaker, and your heart rate is going to be about 40 to 60. If that fails, then you have your bundle of His, and that's about 20 to 40 going through those Purkinje fibers, which is why if you have that complete heart block, the ventricles will go at their own rate, which is about 40 beats per minute. So that's why the heart rate goes really, really slow when complete heart block occurs. And we just talked about that. So they're going to have low cardiac output. Refractory periods, they're here as well. Same reasons. Inactivation gate is in there for sodium. You have to wait for it to reset. That's all the same. Nothing changes with that one. Any additional active potential can produce the arrhythmia, premature ventricular beat, premature atrial beat. All your weird heart rhythm problems all has to do with the way that the SA node or any part of the heart will start getting irritated and start depolarizing like crazy. If the ventricular rate is high, not enough time for ventricular filling between the beats. The heart has to fill. Ventricular muscles have a long absolute refractory period from the onset of phase 0 all the way through midway through phase 3. This protects against circular or re-entry rhythms. Okay, Wolff-Parkinson's White is a re-entry rhythm. Some of these AV node rhythms can be re-entry rhythms. Don't worry about what re-entry is, you got that in ClinPath. But the reason for having a long refractory period helps the heart from cycling on itself. And kind of like what happens is the ventricles will stimulate, but then that electrical signal will get up to the atria, causing them to beat, which causes the ventricles to beat, which causes the atria to beat, and that's that cycle. We don't want that to happen because then your heart rate goes like 250 and you pass out. So that long refractory period prevents these re-entry rhythms from occurring. And beta blockers and calcium channel blockers extend that refractory period to prevent extra heartbeats from occurring. So that's how these two drugs work with premature beats and fast heartbeats. AV node by itself also has a long refractory period. We talked about, we called it the capacitance. But this is what we're talking about, long refractory period. It's a capacitance. It's going to hold on to that charge. Helps protect against rapid atrial rhythms going to the ventricles. The AV node doesn't know which beat is the normal beat versus which one's the extra beat. All it knows is it got an impulse, hold on to it, delivers it. It doesn't know. When you have like atrial fibrillation, all parts of the atria are sending off signals to the heart to beat. AV node doesn't know which one's which. So by having the AV node kind of suppress these things, it prevents the atrial beat, which can be up to like 300, 350 beats per minute, from going to the ventricles, because the ventricles can't go that fast and they'll explode. So it's protective, so your heart doesn't explode. So having this AV node the way it is prevents all that from happening. And again, here's the refractory periods. You can essentially, remember, draw your threshold line. That's where those refractory periods line up. When they go below threshold, we can start activating those inactivation gates again. Sodium starts resetting. But you have to be below the threshold line. And that's where those refractory periods are set up. Autonomic regulation of the heart. So there's a couple of words you got to know. So here we are right here. Sympathetic nerves. Norepinephrine is the neurotransmitter. These are sympathetic nerves. We know sympathetic, they're going to attack the beta 1s and the beta 2s in the heart. If you stimulate these sympathetic nerves on the heart, what effect is it going to have? First one, Chronotropy. Time. How much is it going to be in a minute? So heart rate goes up. Dromotropy. That's the conductance. Are you increasing the conductance through the system? Inotropy is the squeeze of the heart or the contraction. So sympathetic nerves are going to cause a greater contraction, a greater squeeze of the heart. The last one, lusitropy, has to do with how the heart relaxes. The repolarization of the heart, put that way. And the parasympathetic is going to be the opposite. They're two edges of the same coin. Sympathetic is going to speed things up, increase contraction, increase the rate at which everything goes through it, so you have faster heart rates. Parasympathetic, through the vagus nerve, releases acetylcholine onto muscarinic receptors on the heart. Slow down the heart rate, reduce the force of the contraction, slow the conductance, improve relaxation so that the heart can beat better. Okay, so everything in the words I just talked about. Atropine is a muscarinic receptor antagonist for symptomatic bradycardia. So when you get it, give atropine, it blocks the parasympathetic tone, allowing the sympathetic system to go unchecked and your heart rate goes up. That's why you give atropine for bradycardic symptoms. It blocks parasympathetic, so your sympathetic system can take over and bring your heart rate back up again. Now, when we talk about these pacemaker potentials, we said that the action potential rate at which it goes up is slow. However, the rate of depoles in 1 minute is fastest in the SA node. The SA node depolarizes faster than any cell in the heart. That's why the SA node wins. But it's got a slow action potential. That's why on the P wave, it's a nice round shape, not straight up and down. It's a slower action potential, but the rate of action potentials is fast in the SA node. So it's constantly depolarizing because the heart will beat with any beat, the SA node wins. And the SA node being 100. So when we want to increase our heart rate, increase sympathetic stimulation, we just increase the rate of these depolarizations. The SA node picks up the pace, goes faster, and it allows you to increase your heart rate, to increase your cardiac output. So all we're trying to do right now is talk about how we can increase our heart rate. Increase the sympathetic stimulation, increases the rate of the depoles. And remember, excitation, contraction, coupling. Anytime there's a depolarization, there's going to be a subsequent contraction as well. So if you see these, you know you're having a contraction. So every time you see a spike, a beat, 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 beat. More beats, faster heart rate. That's how you increase your heart rate. Okay. This one we went over already, so you can do that on your own. But as far as the QTs, or the different interval things. Again, you'll have more crazy stuff with EKGs in the fall. AA already has EKG now. I hope this answered some of your questions you may have had with regards to the different parts of the complex. The QT interval is mainly duration of phase 2, so your calcium is going to be there. You can cause some weird things happen. You don't need to go crazy with this one, just some crazy things happen. Heart muscle mass is depicted as amplitude on an EKG, so the taller those spikes are, the more muscle mass is being stimulated. So when you have different types of hypertrophies, you have different changes in the EKG because of the amplitude, more muscle. Don't go into detail with that. EKGs also have a lead system. When you think about lead system, think about cameras. Okay, each lead is a camera that's looking at a certain viewpoint of the heart. Lead 1 looks at the anterior portion of the heart. Lead 2 is down here. The camera is facing the inferior portion of my heart. AVL and AVF look at the inferior portion. All your precordial leads are right on top, looking at anterior, septal, lateral portion of the heart. They're all cameras looking at the heart. That's all they do. We have 2 different lead systems, but basically, it's the same image from different views. That's all EKG is. It's looking at the same event from different angles. And it's set up in leads so we know exactly what part of the heart you're looking at, depending on what lead you're looking at. That's all EKG is. It's just looking at whatever's specifically happening in the heart at that time when you had the pads on them. So if they're like, oh, I had palpitations 20 minutes ago, but I'm fine now, you do an EKG, they're not going to show anything because they're not having the palpitations now. So that's what EKG is. Any question about the cardiac electrophysiology? Make sure you understand the SA node, the pacemaker cells, versus the myocyte cells. They both have different properties. The myocyte, they're the muscle ones. They're going to have all the calcium. The SA node doesn't need the calcium. They're not providing any type of squeeze. That is just rapid depolarizations to keep your heart rate up. This last little bit we'll go over today, and we're going to stop towards the end, I think. Yeah, is the cardiac cycle. So we talked about what happens with a beat. That is the electrical portion of the heart. What about the pump? The physical properties, the heart squeezes, how do the valves go into here? That's what the cardiac cycle is looking at. So it's repetitive electrical and mechanical events with every beat. The electrical happens first, then the mechanical or the squeezing. Excitation, contraction, coupling. ECGs can be correlated with our mechanical events. So every P wave is going to precede an atrial contraction. So if you see a P wave on EKG, they had an atrial contraction. The PR segment, which is no apparent electrical activity, but that's when we get through the AV node. Hold on to it before we discharge it. QRS complex precedes ventricular contraction, and the T wave precedes ventricular relaxation. And this thing just repeats itself over and over and over until you die, and then it stops. But until then, it's going to go off on its own. You don't have to think about it. It just does its own thing. So when you're studying this section, really get in your head, is this a systolic event? Is this happening when the heart's squeezing? Or is this a diastolic event when the heart is relaxing? Is this an atrial systole event or is it a ventricular systole event? We're going to graph all this out as we go through it so it'll all make sense at the end. So during ventricular diastole, the heart is relaxed, mitral and tricuspid valves are open, the ventricles fill passively. Then we get atrial systole. Small amount of additional blood is pumped into the ventricles, also known as an atrial kick. But the atrium squeeze, they do provide some filling of the ventricles more at exercise than they do at rest. At rest, it's all just passive filling. Then we get our first phase of contraction. Isovolumic ventricular contraction. What does isovolumic mean? Same volume. Ventricular contraction. We are squeezing the heart, but the volume is staying the same. If the volume is staying the same, are any of the valves open in the heart? Nope. All 4 valves are closed. during isovolumic ventricular contraction. What the heart is doing here, it's pressurizing itself. It's building up pressure to do something, which we'll talk about in a little bit. Okay, it's just building up pressure. Once the pressure is built up enough, then we generate ventricular systole. Aortic valve opens, pulmonic valve opens, heart squeezes, and that pressurized blood leaves the left ventricle, goes in the aorta, and goes to the body. Or if it's on the right side, right ventricle squeezes, blood comes out, goes to the pulmonary, and goes to the pulmonary system. That's what happens during ventricular systole. Blood squeezes, it leaves the heart. The next thing that happens, what has to happen after the heart squeezes? It's got to relax and go back to normal. So we have a next phase, isovolumic ventricular relaxation. Isovolumic again, the volume is not changing. If the volume is not changing or any of the valves open, nope, all the valves are closed. When the pressure in the ventricle is lower than the pressure in the atria, the mitral valve opens. And what do you think happens to the blood? It starts filling the ventricles. Okay, so mitral valve opens when the pressure is lower, and atrial fill with blood during ventricular systole, so that blood is already waiting in the atria, so that when the pressure in the ventricles drop, there's a good bolus of blood in the atria ready to go into the ventricle to be squeezed out to the entire body. These are essentially the main areas of the cardiac cycle. So these are the definitions you really got to know. So let's go back to our graph. Pressure and volume. We said we had our compliance line, right? So there's our compliance line. What is compliance? Able to accommodate large amounts of volume with low amounts of pressure. And we're at a low pressure here. So the cardiac cycle goes in this direction, that way, and that way. As we draw in these lines, it'll make sense. I drew the arrows that way. So that's our compliance line. Let me put that back in. Okay? During this time, we are only worrying about the left ventricle. So all these pressure volume loops is just really talking about the left ventricle. The right ventricle is the same. The problem is the right ventricle has lower pressure. So don't worry about it. It's all the same. So this is the left ventricle. What is going on during this compliance line? What is the heart doing? What's happening to the volume? Increasing. So our volume in the ventricle is increasing. We're filling with blood right now. Okay, this is ventricular diastole. Remember I said compliance, filling, relaxation. That's what's happening right now. The heart is filling with blood because it's relaxed. Now, what was the first phase of ventricular contraction called? Isovolumic contraction, right? What are we doing? Same volume, but no changes in volume, but we're starting to generate pressure now, right? So, at this point, we go up. The volume is not changing. Isovolumic contraction. The volume is staying the same, but we are generating pressure, which we measure in millimeters of mercury going up. Okay? Then, what happens once the heart generates enough pressure? Then what is allowed to happen? Valve opens up, and we're allowed to eject all that blood. So, at this point, we go that way. Okay, do you see why I drew the arrow that way? Look at the volume. What's happening? The volume is going down. Why is the volume going down in the left ventricle at this point? You're ejecting it to the body. So there's not going to be very much left in the ventricle anymore. So the ventricular volume starts to go down. What's the last thing the heart has to do before we reset back to normal? We have to relax. So what do we do with the heart? Isovolumic relaxation, right? Okay? Isovolumic relaxation. This whole thing repeats every single beat. What we're going to do as we start learning more definitions, we're going to alter this curve and this graph. And we're going to make assumptions off this graph. One of the things we can learn right now, stroke volume. If I take the width of this line, is our stroke volume. So if I just took, if this value here was 140 mLs, this value here was 70, what is our stroke volume? 70 mLs. If I take this graph and I make it narrow, so now we are, let's say, we change the line to make this line there. What happened to your stroke volume? Decreased. Okay, if I extend the line out this far and stroke volume comes all the way out there, increased stroke volume. So you see now how the width of this box will dictate your stroke volume. Okay? Now, let's draw this one more time. And now we're going to add some other things on it. Okay, does this make sense now to everyone? I have to label everything. Okay, during that point right there, what valves are, talk about the left ventricle, left side of the heart, so what two valves are we only talking about? Mitral and aortic. Tricuspid and pulmonic on the right side. We don't worry about them. Left side, left ventricle. At that point, what valves, are any valves open? We have isovolumic. So all the valves are closed at this point. So the aortic is closed. Mitral is closed at that point. We now have isovolumic contraction. We are generating pressure. Now the heart is able to eject blood. So at this point, what valve opens? The blood's leaving the heart. Aortic valve is open. What about the mitral valve? Mitral is closed at this point. Blood is leaving the heart. So the aortic valve is open, the mitral valve is closed. Now we have ventricular ejection. Blood's leaving the heart. Eventually, we get back to this point. At that point, what valve is now closed? Aortic valve is closed. What about the mitral valve? Are we filling or are we saying the same volume? Same volume. So everything has to be closed. Mitral is closed as well. Now, the bottom part. We are filling. This is ventricular filling. So what valve must be open for the ventricles to fill? So the mitral is open. What about the aortic valve at this point? This is closed. And now we look at the cardiac cycle in a different way. What valves are open at what parts? If all the valves are closed, we get isovolumic contraction. There's no changes in volume because the doors are closed. If that's the mitral valve, that's the aortic valve. They're both closed. No one can get in, no one can get out. If I open a door, now you can leave through that door. But for now, all the doors are closed. We're stuck in here. This is what the volume we got. Then we generate pressure. Once a certain pressure is generated, which we'll get to in a little bit, as a certain name for it, we have enough pressure to open up the aortic valve. Blood can leave the heart now. So now blood is leaving the heart, and the blood volume is dropping down. Then, aortic valve closed, the mitral valve is still closed. We get isovolumic relaxation. The heart, the left ventricle, is dropping pressure so that it can get below other pressures to allow flow to occur. We're going to keep adding to this graph here. More and more to it. So it's a very, very good graph. Make sure you understand the different properties. We're going to keep adding more to it. There's a diagram called Wigger's diagram. What it does, it combines all these different things into one really, really nice graph. Has electrical events via the ECG, pressure changes in each chamber, volume changes, what's going on with the volume in these chambers, and finally the heart sounds. When do the heart sounds line up on this Wigger's diagram? I'm going to describe this in words, and then we're going to draw it all together on that, and then we'll be done for the day. So left ventricular pressure, the pressure in the left ventricle goes up and down like crazy. At the end of diastole, it gets down to like 0 to 10 millimeters of mercury. At the end of diastole. But it's going to increase very rapidly when they contract. The aortic valve will only open when the left ventricular pressure exceeds the aortic pressure. Remember, the aortic valve is closed. There's still blood right behind it pushing on that valve. The heart has to generate enough pressure to overcome that aortic valve pressure. And as soon as it generates enough pressure through that isovolumic contraction, when it's higher than aortic pressure, aortic valve opens and the blood leaves. What number do you think we use to simulate aortic pressure? Systolic blood pressure. Your systolic blood pressure, 140/90, whatever it is, 130, that 130 is the pressure in the system. That system exerts pressure on the aorta. Your ventricle has to squeeze higher than that pressure to get out. So, if you have high blood pressure, now you're 170s, 180s, that means the heart has to generate higher than 180 during the isovolumic contraction to open that door. That's why high blood pressure kills you, because the heart is a muscle. Just like any muscle in the body, the harder you work it, the thicker it's going to get. The problem is thick hearts don't work well. So you don't want that high pressure all the time. That means your heart has to squeeze higher than that every single beat. So when we look at systolic pressure, that is the pressure the heart has to overcome to open the door. Forceful contraction during ventricular ejection increases to a peak of about 120, corresponding to your aortic systolic pressure. Then left ventricular decreases, and when it's below the aortic blood pressure, that's when the aortic valve closes. And we have now isovolumic relaxation. Now the left ventricle was at like 100, 110 millimeters of mercury. Now it's going to drop all the way back down to like 0 to 10 millimeters of mercury again. And this whole process keeps going along as those pressure changes are there, those pressure differences. So this is what happens with left ventricular pressure. It's very, very low to allow the atria to fill the ventricles. Then the doors close. We generate pressure, isovolumic contraction, to overcome the aortic systolic pressure. Blood leaves the heart. As the blood leaves the heart, the pressure comes back down. Lower than the aortic pressure, the valve closes. Relax. Lower than the mitral valve opens, atria feed the ventricles. As more volume of blood goes into the ventricles, the pressure goes back up, and we keep cycling. Here's your aortic pressure. There is a little vibration caused when the aortic valve closes. That's called the dicrotic notch. You'll see when we draw it. You'll see the aortic pressure, the little dicrotic notch. All this is when the aortic valve closes, the aorta itself is a very, very muscular vessel. It has a little bit of recoil. And when it squeezes, some of the blood will go back and hit the aortic valve. When it hits that aortic valve, it causes a vibration, and that is what your dicrotic notch is. It's just the valve hitting, or the blood hitting the valve again, causing a little bump. That's all that dicrotic notch is. Your diastolic blood pressure is your aortic pressure just before your next ventricular ejection. So normal blood pressure is 120 over 80. 80 is that diastolic pressure, the pressure in the system when nothing is going on. Left atrial pressure, we have to look at the atrial pressure. Normally no greater than 10 millimeters of mercury. So it's going to fluctuate in those 0 to 10 pressures all the time. There are a few peaks noted with the left atrial pressure. One is called an A wave, and the A wave means atrial systole. Okay, so PAs. Have you guys heard? You guys haven't done cardiovascular yet, right? You just started it. When you guys start looking at JVP, jugular venous pulsations, this is what you're looking at here. It's these waves hitting. So you'll see the A wave, the C wave, the P wave, those things. The V wave, you'll see that when you get to the part of the PD, but this is what they're talking about. You'll get there very, very soon. The C wave is due to ventricular contraction. As the ventricles squeeze, there's a little bit of a bulge in that mitral valve. If it's intact and strong, it's not going to do anything. If you have mitral valve prolapse, the valve pops up a little bit and you get a little jet going on. But normally the valve should be closed, and when the ventricle squeezes, the mitral will buckle, causing a C wave. And the V wave is just passive atrial filling during diastole for the ventricles. And when we draw this out, you'll see it all. This is what just defining all the different curves. Left ventricular volumes. So we have a couple of terms, start getting used to, get them in your head. One is left ventricular and diastolic volume. This is the amount of blood in the heart right before systole. So at the end of diastole, this is there's no more blood getting into the heart. We're at the end of diastole, the end diastolic volume. There's no more else coming in. This is what you are going to be left with. Okay, this is the amount of blood in the heart. Normally, it's about 140 mLs in a normal heart at rest. Okay, so normally the heart's going to fill with 140 mLs during each ventricular diastole. 140 mLs. When we have ventricular systole, we only eject about half of that, producing an end systolic volume around 70. Which is why on that other picture, I told you 140 and 70. You're going to have 140 to start. At the end of systole, you're going to have 70 mLs remaining in the heart. The heart does not pump out all the blood out of it. If you pumped out all the blood with every beat, the heart would collapse. It's like priming a pump, like a gas pump. You got to prime the engine. Same thing with the heart. The heart needs some volume of blood in it at all times to keep it its shape, prevent collapse. So we have two new variables. Your end diastolic volume, the amount of blood in the heart right before you squeeze. Your end systolic volume, the amount of blood in the heart right at the end of contraction. So you've squeezed out all the blood that you're going to. Aortic valve shuts, and that's where we're at. So when the aortic valve shuts, you're going to be left with 70 mLs of end systolic volume in the left ventricle. Everyone good on that? So we can determine a stroke volume. Stroke volume is just your end diastolic volume minus the end systolic volume. So how much blood does your heart squeeze out with every beat? Normal is about 70 mLs. Then we also look at another parameter called the ejection fraction, which is basically a percentage of the total amount of blood, how much actually came out. In normal, healthy hearts, ejection fraction is 55 to 65%. That is a normal ejection fraction for healthy hearts. When people have had heart attacks, a heart attack is a myocardial infarction. You kill the tissue. You're killing off the myocardial tissue. When you do that, there's no more contraction anymore. The heart's not going to squeeze as well. So people who have had heart attacks, damage to the heart walls where they can't squeeze as well, their ejection fraction can drop to like the 20s, 15%, which means that the heart can only squeeze out 15% of the blood every beat. Is that enough for the systemic circulation to do anything? Not really, so they get very winded fast. They have no energy because they can't pump out the blood. As the ventricle fills, compliance decreases and the ventricular volume plateaus, called diastasis. Atrial systole produces the final kick to achieve a full end diastolic volume. Yes?
So going back to the ejection fraction, that's end systolic volume over the end diastolic volume?
No, it's a percentage of 70 out of 140, it's 50%. That's all it is. It's making a percentage out of it. So that's the left ventricular volumes. How does the volume change as we go through a heartbeat? So this is the diagram itself. If you can understand this diagram going this way and knowing what goes down, big leg up on a lot of things for cardiovascular. This combines everything. So left atrium, what we're going to be doing underneath is anything that's occurring during the systole of the atrium or what's going on in diastole. Or diastole of the ventricle, systole of the ventricle, and then finally diastole. What is going on in each of these phases? So the first thing is the mechanical event. What is going on for the cardiac cycle? Okay. Okay. So, mechanical events. What is going on in this section right there? I'll blow it up even more. We have the first part of systole. What is the first part of systole for the ventricles? What is it doing? The first part. Isovolumic contraction, right? We're trying to generate the pressure. So the first step, okay, isovolumic contraction. Then we have rapid ejection, and we have slow ejection. So first thing that's happened, isovolumic contraction. Then we have rapid ejection of blood. Then it slows down a little bit. Then we are now in ventricular diastole. What's the first thing that happens during ventricular diastole? Isovolumic relaxation. Then we have rapid filling, and then our slow filling. And again, it just repeats itself over and over and over again. So this is the phase of that cardiac cycle. Now, let's talk about the pressures. So we're going to do different colors here. Red is going to be aortic. Blue is ventricular. And the green is atrial pressures. So we're going to put all three pressures on this one graph. The first thing we'll do is aortic pressure. What is the normal aortic pressures? What's your normal blood pressure? 120 over 80. So we're going to do our graph for aortic pressure, 120 over 80. So 80 is at rest. There's our aortic pressure. In the next segment, is there any changes in pressure in the aorta? Nope, we're at isovolumic contraction, so this doesn't change. Stays in the same line. Now, we are ejecting the blood, right? So, we're going to go up to 120 and come back down to there. When systole stops, we have a little bump in the aortic pressures called that dicrotic notch. It's right here. And then, oops. Okay. And we kind of just hang out there for the rest of the time. Okay, so that is the aortic pressure. Let's do atrial pressure now. What are the atrial pressures normally hanging out at? 10. Very, very, very low. Why is the atrial pressure there at the bottom going up? Atrium are filling. If you add volume, you add pressure. So we're filling. This is left atrial systole, remember? So the atrium are squeezing. Okay? So at this point, they don't really move much. Remember, this is isovolumic, so no changes in volume, no changes in pressure. Then we get a little bit of a squeeze. There's your first initial bump, and that is your C. The C wave, we talked about left atrial waves. This is the C wave due to contraction of the ventricle. So you get a little bit of a bump in pressure in the atria because of mitral valve, atrial pressure because that mitral valve kind of gets pushed a little bit. Then we come back down and wait. And then finally, during isovolumic relaxation, we get a little bit of an increase, and then back down. Oops. And now it just waits for the next event to happen. This wave, can't see this. V wave, and there's your A wave. So those three little wave patterns, that's where they go. So this is still just dealing with aortic pressures and the atrial pressures. Now let's talk about what happens to the ventricles, because this is what matters when it comes to filling and pressure generation, all that stuff. So during ventricular diastole, what is the heart doing? What are the ventricles doing? Filling. We're in ventricular diastole. In order to fill, the ventricular pressure has to be below what? The atrial pressure. So in this case, this line is right along the edge till we get to that line. At this line, they converge because they're equal now, and the mitral valve closes. Now, what happens to ventricular pressure? We're increasing. This is isovolumic contraction. So the heart is generating pressure until it crosses that line. Does everyone see the crossing occurs when we switch from isovolumic contraction and now we go to rapid ejection, where the blood's leaving the ventricle through the aorta because the ventricle has now generated more pressure than the aortic valve. Aortic valve can now open and blood can leave. So the pressure overexerts it. Then, as the pressure comes back down, eventually it's going to go lower than the aortic pressure. When we go lower than the aortic pressure, the aortic valve now closes. And now we have isovolumic relaxation. The pressure in the ventricle has to relax to drop below atrial pressure so the mitral valve can now open and the ventricle can now fill. So this blue line is going to come all the way down until it gets just below the atrial pressure. Now we're lower and we're going to work our way up, eventually cycling back over to the front. So you can see where the ventricles, when they overcome the aortic pressure, the aortic valve opens. When the ventricular pressure is less than aortic pressure, the aortic valve closes. When the ventricular pressure is less than the atrial pressure, the mitral valve opens, allowing the heart to fill, or the ventricles to fill. When ventricular pressure rises above atrial pressure, the mitral valve closes, and now we're ready to start squeezing. It's a cycle. It goes over and over and over and over and over again. This is just dealing with the pressure changes. So think about what the pressure changes is just opening doors. We have to be higher than a door to open it. We have to be lower than a door to close it. That is what's going on with the pressure. The heart sounds that you hear. Okay, make sure I have this right. There's the first sound, and here's the second sound. And then you get more sounds on this side. And there we go. Okay. This is S1. What valve is closed right before S1? Right here. What valve is closing right there? Mitral valve. So the S1 is your mitral valve closing. Here's S2. In S2, work your way up. What valve is closing right there? Aortic valve closes. So your S2 sound is the aortic valve or pulmonic valve closing. This last little blip out there is S3, and this other one over here is S4. Those are abnormal heart sounds. But as long as you understand S1 to S2, any sound that you hear between S1 and S2 is a systolic murmur. If you hear any sounds outside of S2 going back to S1, those are your diastolic murmurs. When you listen to the heart, start getting used to hearing lub-dub, lub-dub. The lub is the mitral valve. The dub is the aortic valve closing. That's all you're hearing is the valve closing. If you hear which is happening in between S1, that's a systolic murmur. If it's that is happening after systole, those are diastolic murmurs. Figure out which ones those are later on. But when you're hearing things, start getting used to, especially in PD lab when you listen to the heart. Don't just be like, okay, here are the locations. Take your time, listen. AA, you guys got to do your own physical exams too before you give any anesthesia to a patient. You better listen to the heart and know what you're listening for, because there are certain valve abnormalities you don't want to be given anesthesia to. So you still have to do your own physical exam as well. So the last little bit is going to talk about the EKG and the ventricular volume. And here we are. Okay. Ventricular volume. Put it in red so it stands out. So we're filling, right? Ventricular volume, we're filling. It should go to 140, it's just that I ran out of space. So don't worry about the number. Know it's 140. Okay, what happens in the next phase? Should the line move at all or go up and down? Should it be stable or up and down? What's the next thing that's going to happen? Isovolumic relaxation. Is there going to be any changes in volume? No, so it stays the same. Now, what's the next thing that's going to happen? We had isovolumic contraction. What's next? Ejection. So if the blood's leaving the heart, what's going to happen to your ventricular volume? Decreases, and it's going to go down till it hits that line. Why this line? Because we learned up top, at that point, the volume has dropped in the ventricle, the pressure has dropped in the ventricle, and once the pressure is lower than the aortic valve pressure, the valve closes, and there's going to be no more movement, because what phase are we going to be in? Isovolumic relaxation. So isovolumic, there's no changes in volume because all the doors are closed. Then we go to filling, and the whole cycle starts up again. We fill back up. Okay, remember these numbers are around 140 mLs. I drew it lower because I ran out of space. On your original copy that's in your module right now, it's written out the proper way. But that's what happened with the ventricles. Yes?
Is the value at 0.4 supposed to be like 70, quote unquote?
Yeah, I mean, that's where it's supposed to be. 140 to 70 are normal ranges. I just exaggerated it. But yes, it should be 140. The bottom should be around 70 mLs. Because their normal stroke volume is 70 mLs. The last little bit is our EKG. we'll put this together. So we know we are in the beginning of ventricular diastole. So the last little bit is the beginning, is the end portion of the P wave. Now, at this point, we have what? What happens in that next segment? Right here. That's your isovolumic contraction. So the heart is contracting. If the heart is contracting, we have our QRS complex. So the QRS happens here, right at the beginning of isovolumic contraction. The relaxation happens here. And then the whole thing starts to repeat. I should change the colors. Okay. And this is the beginning part of the P wave again, and there's the rest of the P wave because of the way the cycle was on this page. Because we're trying to align it with ventricular filling. This is a lot. I know it's a lot. We're going to continue working off of this graph for the rest of the time we're in cardiovascular phys. So this graph is going to be very important. We're going to piece out parts of it, talk about it more. But again, if you can talk your way through the mechanical events, know the order of the cardiac cycle, then work your way top to bottom. So in isovolumic relaxation, what is happening to the volume? No changes, what's going on? And work on from there. So review this stuff. On Thursday, we're going to start with this again and move on through different parts of tweaking and all this. Let me know if you have any questions. Otherwise, I'll see you guys on Thursday.
Thank you.